Dr. Silver's Pathology. Adenocarcinoma in situ, HPV-associated, of the uterine cervix. Hi guys. This is Dr. Silver. Today I'm going to be talking about the microscopic features of cervical adenocarcinoma in situ. Before we look at the actual case, let me give you a brief explanation on the adenocarcinoma in situ, aka AIS, of the uterine cervix. In the 5th edition of the WHO classification of the female genital tumors, cervical adenocarcinoma in situ, AIS, has been divided into HPV-associated and HPV-independent groups. Because HPV-associated AIS is much more common, today's clip will cover only the HPV-associated AIS. As the name implies, it is a precancerous lesion which can develop into HPV-associated adenocarcinoma. Since most women with AIS are asymptomatic, most lesions are detected either during screening or fortuitously on an endocervical curettage. Cervical punch biopsy, cone or loop excisional biopsy performed during the workup for squamous intraepithelial lesion, SIL. AIS, HPV-associated or associated with infection with high-risk HPV, most notably HPV-16 and HPV-18, or HPV-45. Of the AIS cases that are diagnosed by cytology and/or biopsied by a colposcopist, 99% are HPV-associated. Of these, over 90% are positive for HPV-16 and/or HPV-18, a proportion similar to that seen with invasive cervical adenocarcinoma. Microscopically, AIS is characterized by the presence of endocervical glands, lined by atypical columnar epithelial cells that cytologically resemble the cells of invasive adenocarcinoma but which occur in the absence of invasion. The cardinal features are columnar cells, often mucin depleted, with nuclei that are usually pseudostratified and hyperchromatic. Along with easily identified apical mitotic figures, floating mitoses, and basal karyorhexis. Note that these are the same features that are also important in invasive adenocarcinoma, HPV-associated, of the uterine cervix. AIS is confined to the pre-existing glandular architecture, therefore retaining a lobular architecture. This absence of stromal invasion draws a line between an AIS and an adenocarcinoma. These figures are from the textbook. On the left, you can see on the low power view that endocervical glands are lined by atypical columnar epithelial cells. The middle figure is a high power view of the lesion. These columnar cells have elongated, cigar-shaped, hyperchromatic nuclei with coarse granular chromatin. The amount of cytoplasm is greatly reduced and there is only minimal intracellular mucin. This produces an increased nuclear cytoplasmic ratio. The cells are crowded and pseudostratified, forming two or more rows. Typically, some glands show an abrupt transition between normal epithelium and AIS, as demonstrated in the figure on the right. Some ancillary tests can help diagnose the lesion correctly. Immunohistochemical staining can be quite useful in distinguishing AIS from other glandular lesions. Most, but not all, AIS lesions demonstrate diffuse nuclear and/or cytoplasmic immunoreactivity for P16, which is a tumor suppressor protein. It is a result of compensatory upregulation related to interference of the HPV oncoprotein, E7, with RB1. It is worth noting that positivity is defined as strong block-type staining. As non-neoplastic proliferations such as tubal metaplasia may show patchy P16 staining, it is critical to distinguish between block-type or every-cell staining and patchy staining, with the block-type pattern being confirmatory of the diagnosis given appropriate morphology. One must also be aware of other glandular neoplasms with block-type P16 staining. Reactive or reparative lesions and microglandular hyperplasia are usually P16 negative. In addition, although not necessary, high-risk HPV RNA in situ hybridization testing can help to adjudicate the HPV status of these problematic cases and inform the correct diagnosis. Last but not least, immunohistochemical staining for Ki67 can be handy. Ki67 proliferation index in AIS is much higher than non-neoplastic glandular lesions. Over 30% of the cells in AIS lesions usually show nuclear staining with Ki-67. And in most instances the majority of AIS cells will stain positively. Some cases of tubal metaplasia can be diffusely positive for P16, and in these instances, a Ki-67 IHC is useful to help distinguish these lesions from AIS. The Ki-67 proliferation index in tubal metaplasia and endometriosis is usually quite low, less than 10% of the cells will stain positively. On the left is a classic AIS, showing sharp demarcation between normal and neoplastic tissue. The neoplastic tissue stains strongly with P16 and has a high Ki-67 labeling index. On the right is a typical tubal metaplasia, which typically shows patchy heterogeneous staining with P16. I guess we are now ready to move on to the real-world case. This is a leaf conization specimen. Even on a scan view, you can spot the area with a darker tint. On a low magnification, hyperchromatic cells replacing the normal endocervical glands are seen. As discussed earlier, a sharp demarcation between the normal epithelium and AIS is seen within a gland. On a high magnification, I captured a spot where you can see the striking difference between normal endocervical epithelium and AIS. The normal endocervical gland is lined by a simple columnar epithelium with small nucleus confined to the base of the cells, with mucin filling the upper luminal portion of the cells. The size of the nuclei are small compared to the cytoplasm. In contrast, lesional cells of the AIS are columnar cells whose nuclei are hyperchromatic, elongated, and pseudostratified. The nuclei are not confined to the basal portion. It looks like they are crawling up to the surface. On immunohistochemistry, the lesion showed block positivity for P16, and high proliferating activity on Ki-67 staining. What a perfect example. Before we wrap up, take one last look at the essential and desirable diagnostic criteria. Pause for a moment if you need. References are as follows. Thank you for listening. If you liked the video, subscribe Dr. Silver's Pathology. See you next time.